Hello everyone, I'm Dr. Matthew Reedy with Trillium Dermatology, here today with our Mohs Micrographic surgeon, Dr. Bryan Baillis, and our founder and medical director, Dr. Helen Torok. We are here today to talk about skin cancer. In particular, we're going to discuss a technique for removing skin cancer called Mohs Micrographic surgery. Now for skin cancer, we know prevention is key. However, if you do unfortunately develop skin cancer, early detection is critical. A lot of skin cancers are curable, especially if caught early. So we're going to start actually with Dr. Torok. Before patients head over to see Dr. Baillis for surgery, they oftentimes start seeing one of the general dermatologists like Dr. Torok or myself. So if a patient comes to see you, Dr. Torok, say I'm your patient. I have a new bump on my nose. It's been there for 6 months. I initially thought it was a pimple. It's growing, it's pink, it's starting to bleed. Do we hear this often?
Oh my gosh, that's classical description.
Classic.
And people think it's a pimple.
Yep.
So
Yep.
they mess with it.
Yep, so tell the viewers then what to expect from their initial visit with one of us before they would head over to see Dr. Baillis.
So first of all, we would examine them and see what exactly is going on. Not just the little area, but the face, the back, and assess the damage on the skin. We take our dermoscope and look for the little telangiectasias, little blood vessels, classical basal cell skin cancer, which is the most common one we see in this country. So we numb the area, and then we take a little shave of the area, trying not to make a big scar, and then wait for the biopsy results. But we talk to them, if it is a skin cancer, you'll have to see Dr. Baillis because it is the face, and that's an area where you want to do minimally scarring procedures, take minimal tissue out, but get the whole tumor out.
Mm-hmm. Exactly. Okay, so after we get the pathology report back, then we call them and schedule Mohs Micrographic surgery. So Dr. Baillis, to start, can you explain why it's called Mohs surgery and what training was required, which you completed to become a Mohs surgeon?
All right, good question. So the first thing is, Mohs is not an acronym, and that's probably the most common thing we get. What does MOH stand for? And it's actually all named after Frederick Mohs, which you guys know. So he was actually a surgeon back in the 1930s. So it's almost 100 years now.
Yeah.
And he was the first one to sequentially remove tissue and evaluate it. And that was actually what was a lot different than the old Halstead thinking of just bigger was better. So the name Mohs surgery, which a lot of people will hear, is one thing. And then micrographic surgery, as you alluded to, Matt, that's the more technical name. That's just reference to the use of the microscope, and then the graphic comes from the mapping of the tissue. So Mohs surgery, micrographic surgery, Mohs micrographic surgery, all used interchangeably. And it's evolved a lot over the last roughly 100 years to the form it is today, but it's all really just an ode to Frederick Mohs, who developed it. And then as far as training, your Mohs surgeon, whether it be here with us or just anyone you see, they're going to be a classically trained dermatologist. So Frederick Mohs is actually a surgeon, but Mohs surgery and a lot of skin surgery actually plays a very, very large role in just the normal dermatology training. And once you complete that, you have a lot of exposure to it, but you're going to do the additional year after that, and that's going to be more the reconstructive surgery, more detailed pathology, and then again, it just gives you 1 year, just a lot more focus on it. And then after that, you have the ability to do both general derm, focus more on surgery, and ideally, be able to give all your time to that.
Mm-hmm. Great. So yes, to become dermatologist, you have 4 years of undergrad, 4 years of medical school, 4 years of residency, and then we were done. Dr. Baillis kept going for a whole nother year of Mohs Micrographic Fellowship, so very well trained. Can you briefly summarize kind of the method and the step-by-step process?
Yeah, absolutely. So I think the biggest thing to know about Mohs surgery and any surgery is the pathology. That's what's different, right? So to compare that, let's go back in time a little bit and compare it to just your standard wide local excision. I think that's what a lot of people don't know. So a wide local excision, which a lot of people are familiar with, is you have a tumor, a predetermined margins taken around it. Might be 4 or 5 millimeters, might be a centimeter more for melanomas, right? So that's taken around your spot, and usually a little elliptical shape or football shape, which a lot of people are familiar with seeing, is taken off. Sent off, and then the pathologist is going to get that tissue, and it's sliced up like a loaf of bread. Pathologist then is going to look at a few different slices. They're going to look at all the edges, the floor, but they're only looking at about 5% or less. Now they'll get slices from the different quadrants and the tips, But they're looking at that, and if they don't see tumor, they're going to call it clear. If they see tumor, they're going to call it positive. The key is, if you have an irregular tumor, something aggressive, it may get missed. But by taking a wider predetermined margin, you're kind of trying to prevent that. So the difference with Mohs surgery is the pathology more than anything else. Both are going to involve cutting and stitching, but with Mohs surgery, you're going to slice it like little pancake slices. So instead of a bread loaf, it's little pancake slices. Those will get pushed down, and every cell at the edge then can be seen, every cell underneath can be seen. So you're looking at 100% as opposed to 5%. That's the biggest difference between the two of them. And that allows you then, you don't have to take a larger predetermined margin right off the gun. You can start just outside of what you see clinically, which can be a big difference. Millimeter or two on the nose is a lot different than 5 millimeters when you're starting, right?
Right.
So what that translates to for the patient is they're usually in the office for a few hours, but they can expect it's a local anesthesia procedure, so you don't have to do NPO after midnight. There's nothing like that. You can eat breakfast and you come in. They're going to come into the room, meet us, meet my staff, or anyone that they're seeing. And what they're going to do then is we're going to mark it, compare it to a picture ideally, because we all want to be on the same page when we go forward with any kind of surgery. Get it numbed up just like the biopsy, so just a little local anesthesia, and then that first pass is taken. That'll then go off to the lab. Anywhere from 45 minutes to an hour and a half, then we'll wait while it's processed. And again, it's going to get sliced up, and then we'll be able to have them on microscope slides after that time period, and we'll be able to review everything at the edges. So what we're doing is we're looking for further tumor. If we see tumor at the edges or the floor, we know where we have to go back, and that's where the kind of graphic or map-based nature comes from, right? So it helps kind of show us where. So if it's between 12 and 3 o'clock, we know to go further there. We don't necessarily have to take more of everything. About 2/3 of the time, though, you're clear on the first pass, and that's just statistically kind of where things fall. And about 1/3 of the time, we'll have to go back. There might be roots if it's been there for a while, or an irregular tumor, and we'll go back. And that happens over a few-hour time period. We go till the tumor is cleared, and then we'll sit down and we look at all the different options for getting things fixed up.
Yep, exactly. So if you ever develop a skin cancer on your back, for example, if it's a small basal cell, you oftentimes won't require Mohs surgery. You can see me, you can see Dr. Leonard Torok, you can see Dr. Andrasik, and we could do a standard excision like Dr. Baillis mentioned, so we could treat that on the general dermatology side. Dr. Torok, can you explain for the patients what body locations are common which would qualify for Mohs, because not every skin cancer needs Mohs or will qualify for it with insurance.
But obviously, anything on the head and neck, we always send for Mohs. It doesn't matter the size, the age, because that is a very small area. So as Dr. Baillis said, you have precise, exact measurements where you can see the advancement of the little, as I tell patients, your skin cancer is like little roots, and you want to make sure you get all those little roots that are projecting out. So you have to follow it carefully, but you want to spare tissue, and that's the important thing on ears, nose, face, neck. But the other area that we're also looking is recurrent skin cancers that have been excised and have the little roots that have not been totally excised. So the recurrent ones, you will always do Mohs, all right? There are skin cancers called morphia basal cells, which are like a rock, they're scarred-like. Those you have to do Mohs on, or wider excisions, because those have a higher recurrence. Anything larger than 2 centimeters, which is almost an inch, you also want to do Mohs because they have a higher recurrence rate. So those are the areas we would look at for Mohs, other than, just the head and neck also.
It's like real estate, right? It's location, location, location.
True.
Where do you get
Very
most
well
of the sun?
said. Yes, very well said.
I always tell patients, think of a water glass, right? When you're born, you have an empty water glass. It's your stem cells in your skin. Over time, drop of water, drop of water, drop of water. Every time you're out in the sun, every burn, you get a few more. And we all fill those glasses, right, at different kind of rates depending on our predisposition. So eventually, a single drop's going to be that critical mutation, right? You get a little skin cancer. But it's also why you're filling a lot of glasses. It's also why people who have one, they're at risk for others. But where's that going to happen? Typically, head, neck, hands, feet. We will do, like you said, there's appropriate use criteria for everything. So not everything is one thing. There's always different options and you weigh those. So you're correct. More aggressive things, trunk and extremity, may be appropriate for most. Very small things on the head and neck, occasionally maybe be able to get away without. So you weigh everything, but by and large, the large bulk of what we do will be head and neck.
So when you come and see us for a small excision on the trunk, We take larger margins around it, we send it away. You don't get the results back for 10 to 14 days, so we don't know if the margins are clear. The nice thing about Mohs is you leave that day knowing that Dr. Baillis checked 100% of the margin, all the cancer is clear, so it's very reassuring for the patients. And we know the cure rates for Mohs micrographic surgery are higher than for standard excision. So Dr. Baillis, can you talk a little bit about cure rates and about scar expectations for patients?
Sure. So I think a good point to just talk about some of the benefits, concerns, and that kind of thing, because those kind of all fall in. So you're correct, the cure rates are going to be higher when you look at 100% of anything, right? And typically in well-trained hands, most surgery, quoted numbers are 99% or above. It's not 100%, nothing's 100% unfortunately, but it's the highest rate that's out there. It's why it gets kind of billed as the gold standard for skin surgery. Some of the other modalities that are out there, they're all options, but they just carry kind of different cure rates and recurrence rates with them. With that said, so some of the things we talk about, good things. Precision and accuracy, you're looking at everything. Real-time results, you're going through it that day. So you're not waiting over the course of a week, you're not getting a change in plans after a week or two. You're not typically having an inpatient stay either, which is nice. So the patients get the real-time result, which is nice. You come in with cancer, ideally you leave without cancer. And we kind of walk every step through the way with them that day. And then cost effectiveness actually too is one of the main benefits. There's a lot of studies and meta-analysis that have compared Mohs surgery to standard wide local excision and then everything else. And when you compare just surgery centers, inpatient, outpatient costs, or for example, recurrence rates and doing the same thing over and over on certain areas, fortunately, Mohs surgery and ideally doing something once and getting things fixed up has shown a lot of data that supports it too in the long run. So there's a few of the good things. Again, you're accurate and you're sparing tissue, which I think most people are most concerned about. But that also leads to some of the patient concerns too. And I think the main one is just knowing surgery, it is surgery, right? So a lot of patients come in, they're like, you just take a little eraser, get rid of it, and that's it. And it's not quite that true, right? You're going to remove it, whether it's standard local excision, whether it's surgery under anesthesia, whether it's Mohs surgery. Yeah. It does involve cutting, does typically involve stitching, and it does involve some sort of scarring over the time period. Now, we're on the same page with all of our patients. We want the best outcome that we can get for them too, but it is surgery. And that alone can be anxiety provoking for a lot of patients, especially when you think about the middle of the face, the complex anatomy, and just the things that kind of how we carry out through the day. So surgery, or knowing that you're going to kind of have a healing process to go through, can be anxiety provoking. But again, we try to walk through that with our patients, and that's probably one of the main concerns.
Yep. I also tell my patients that when they are scheduling Mohs, it could be a short day, especially if he gets it on the first pass. But like he said, he takes tissue, he just takes a very narrow margin around it, gets processed, which can take 45 minutes, which can take an hour. So if the margins are positive, then he has to do it again, which can take another 45 minutes to an hour. So I always tell patients, could be a quick day, could be a long day. Skin cancers are unpredictable. We don't know how far the roots go down. So I always say, have the whole day available. Bring snacks, bring a book, bring something to do. The nice thing is at the end of the day, your cancer is going to be gone, but it's an unpredictable day, so just prepare yourselves. And then I would say his work, from my experience, I see patients back after they have Mohs surgery. I see them for their skin checks, as do you. Dr. Torok, what do you normally see after they've had Mohs? What are patients saying about their experience with him, with the Mohs team, with the whole procedure?
Well, first of all the women love you. They do. He has such a caring attitude.
We're probably lying now, but that's
No, they truly, truly appreciate your kindness and your care. And the one thing that they always comment to me is, he called me the next morning to see how I'm doing. That's the first thing out of their mouth when they come in. He called me, and that goes a long way for showing that you care, that you want to make sure that they're doing well. They're going to get a great result. And I'm telling you, 90% of the time you can't even see the incision.
The surgeon who trained me, Joel Cook, he called everyone the next day. He made it a point beyond the surgery day to be available for your patient. And I think it carries a lot of weight in the long run because, again, you're going to get to know these people. It's not just a hi and a bye. And I think establishing that rapport early on is important because, again, those water glasses, it's not the only one filling up. You're going to see those patients over. And
you're
again,
gonna see them again.
myself and I have a wonderful staff over there, and I think our group does a good job too. I think everyone actually cares what they're doing. And I think that goes a long way. So
Yeah, because your second skin cancer, 50% incidence, right?
roughly,
Roughly 50% of the time, you're going to get a second skin cancer. So that's pretty high. So that rapport is important.
It's
Yeah,
important.
Yeah.
But I agree. A lot of times I'm doing skin checks on these patients who have had Mohs, and I'm looking at their face, and their Mohs was on their cheek, and I'm like, wait, which cheek was it? I'm like struggling to find it.
Right.
You will have a scar anytime you have surgery, so we don't want to set unrealistic expectations, but his work is incredible. I always tell patients we're very lucky to have him.
Right.
They rave about him and his team, and I have to remind them, hey, we're pretty good on the general derm side too, But no, they love it. And
You always have a 5-star review.
No, we care, but fortunately, I mean, any Mohs surgeon too, right now you've had to go through fellowship. You've had, and you were trained too, Matt, and even just during your training, you get a lot of exposure, and you do the additional year. So there's a lot of skilled people, but again, I think we try our best here.
But when you summarize it, 12 years after high school, that's a lot of years. 13 to 14 years after high school, that's a lot of education.
It's a lot.
Yeah.
It's a lot. Okay. Any other comments?
No, I think if you want your best results, come in early. You see that spot, don't think it's just a pimple. Come in and get a check. You won't have as much of a layering. You may have just one layer of Mohs rather than 2 or 3 or 4 and be there most of the day. So come in early.
I agree. I think if you have a predisposition, you've had skin cancer, don't be an angel with wax wings. Don't fly too close to the sun, right? Come in, get checked out early. Earlier is better. And again, I think we have a great team here, and we'd be happy to help too.
Yeah.
Exactly. So we catch things early. It's easier to remove. Scars going to be smaller. So again, prevention is key. Wear your sunscreen. Have your cancer screenings. Early detection is critical. If something's changing, get in, see the experts, have it evaluated, and we'll get you taken care of. The nice thing here at Trillium Creek is it really is a one-stop shop. We have 5 locations. We have our Medina office, Wadsworth, Worcester, Brunswick, and Strongsville. You come in, you see one of us here in the community, we biopsy you. Your pathology is read by Dr. Josh Weaver. He's our dermatopathologist. He reads slides right here at the Medina location. If you need surgery, you go see Dr. Baillis for his Mohs micrographic procedure right here in Medina. You don't have to go downtown Cleveland. You don't have to go to Columbus to a big university setting. It's all treated right here. So let us know if you need us. Give us a call, 330-725-0569. Visit us online at tcohio.com. Thank you.